So what we saw from China, and I don't think we can really trust the statistics out of China, but we saw it looked like it was pretty rapidly contained. That was step one. And then step two, we saw countries like Hong Kong, Taiwan, Singapore, all with early cases, but this ability to have very relatively few and then very few deaths. And I think that actually really gave us a false sense of security about this virus. And what we didn't understand at the time, I think we're increasingly coming to understand, this is where testing is a big part of the story, is that they had just a fundamentally different strategy and a different state capacity to basically implement that strategy. In many ways, this comes back to the fact that they had a huge warning for this. They had SARS. I don't think we can underestimate just the psychological impact of SARS on someone like Hong Kong or Singapore or South Korea, who did an extraordinary amount of preparatory work to ensure that if there was a future outbreak, because they said to themselves, this isn't the first outbreak that's come out of these wet markets in China. This is a huge risk. We're very close to these countries. We need to have a good strategy in place. And a huge part of that strategy was this sense in which we are going to track and find every single case. So I was looking back through this, and at the start of January, even before China admitted to human transmission, Singapore had a strategy in place that said, we're going to start identifying people who come in with a pneumonia or an unexpected respiratory issue. And we're going to start developing our case definition, which we're going to send an alert out to all our hospitals and all our doctors and all our healthcare facilities. And we're going to say, this is something to watch out for. Now that happened on January 2. This was extremely early. And then they very rapidly developed tests. Now, admittedly, the UK did the same. The UK was very fast to develop a test, but the difference in strategy with the UK was, and we saw this kind of explicitly outlined by the government when they started talking about containment and then delay phases. Containment phase was something that basically said, we're going to try to find the early cases and we're going to try to track those cases. And that worked for a little bit, but it turns out we just didn't have the testing capacity to do that. And the essential reason why we didn't have that testing capacity, and this has been my focus from a public policy perspective, is this decision to centralize testing initially in a single facility, Public Health England lab in London, and then this hesitancy of the bureaucracy to extend that out. So initially, one facility, it wasn't until about February 10, they started involving other Public Health England facilities. There's about a dozen labs run by public health authorities. At that point, they said they could maximum do 1,000 tests a day, which at the time seemed like enough, but in retrospect was nowhere near enough to be able to track everybody who could potentially get the virus. Singapore spotted very quickly that 3/4 of the cases, the first 100 cases they had, didn't come internationally from travelers. They came from domestic transmission, which was basically similar that domestic transmission is a big issue. But the reality is if you came down in February with like a flu-like symptom, you hadn't recently been to China, there's no way you get a test. There's no way you'd know that you need to isolate. So you were more likely to go out and spread that, particularly with something like COVID-19 that we now know has a 3, 4, 5 day asymptomatic period. So we weren't testing people broadly. We weren't isolating. We allowed this effectively this huge outbreak to spread. And I was looking back, there's a document about the 26th of February when Public Health England said, well, there's no evidence of a community transmission in the UK. In retrospect, an epidemiological impossibility. There was spread at that point. It was clearly, in order for the number of cases and deaths we saw into early March, there's no way there wasn't community spread in February. So the NHS, the Public Health England centralized it. They only started to let NHS labs do it weeks later into late February, March, and still even into late March, they weren't letting the private sector do the testing. They weren't letting charities do testing. They weren't doing universities do testing. And then we got this great outrage. And this is when we released our report on the 1st of April. I'm saying, we've got these universities offering. They've got some of the world's leading scientists. They've got some of the materials you need. They've definitely got the machines you need to do the test. Why are you not letting them do the test? And what's now emerged is that Public Health England had a literal strategy that they called command and control, believe it or not. Sounds like something straight out of the Soviet Union, where they would decide themselves to do all the testing. And the reality is, it sounded like a good idea. It sounded like you want to try to ensure you've got quality of testing. You do want the test to be accurate, although you can exaggerate the importance of that. Testing is just so important that even if some people are told falsely that they have the virus, it's still better just to get them isolating than it is to risk somebody transmitting. So in some ways, more tests is really what's key, even if it's not 100% accurate, even if it's 80 or 90% accurate.
Yeah.
Um, but basically, we didn't get this broad testing. The government didn't really have a broad testing strategy, and they're only starting to develop that now. So we've got these fantastic lab now at Cambridge with some of the UK's leading pharmaceutical companies. That's not going to be set up until early May with 30,000 tests a day. And still Public Health England is quite hesitant about getting even small labs to do testing. So there's a COVID-19 volunteer test network of these labs that are for free testing frontline health workers, but the NHS doesn't want to, and Public Health doesn't want to formally involve them. It's kind of an informal process at the moment in the testing regime. So I think we've got this fundamental issue of centralisation and control that has really hampered testing in the UK, and that's meant that we haven't been able to track the cases. We haven't been able to prevent this huge outbreak. But right now, it's having two effects. One, it's meant we haven't been able to get NHS workers back to the front lines because they'll have to isolate. It's the first issue. Secondly, I think we're seeing this in the aged care front, that you're not getting huge testing you need in the aged care facilities, and now there's emerging outbreaks there. And three, it's setting us up particularly badly for being able to withdraw the current social distancing measures we've got in place. Because what we really want to do is move from these very broad measures where everyone is locked up in their homes, more or less, to measures that are very targeted, where we maybe try to shield people who are over the age of 70, and then we let people get back to work because we know the economy is and jobs are so essential to saving our lives in the long run anyway. But we can't really do that unless we can spot new outbreaks. And we can't spot new outbreaks unless we're testing pretty broadly in the community. Whenever anyone comes down with a cough or a flu or loses their sense of smell or taste, as we now know might be a symptom, we should be testing very broadly and then spotting people who have issues, and then using technology to identify people who've been near the people who now need to isolate and instructing them to do the same.